Hello, my name is Colin Coyne, and as Executive Director of Meta Global, on behalf of all of my colleagues, we'd like to welcome you to this important and timely video presentation. Meta Global is a global education service provider that seeks to connect practitioners, educators, and institutions to deliver a transformative model of healthcare education. We seek to improve the outcomes of populations by providing access to globally renowned faculty in a way that addresses present and future needs and through the lens of competency, character, and caring. The series you're going to view today addresses the essential topic of cardiac complications from COVID-19. The series is divided into 6 parts, which can be viewed individually or consecutively as one seminar. We'd like to thank our partners at Brookwood Medical Health Systems and Dr. Farrell Mendelsohn for providing access to this content. We hope that it adds to your practice. We hope you enjoy the presentations, and we particularly wish you continued good health.
Hello, I'm Dr. Donald Lloyd-Jones, President of the American Heart Association for 2021 to 22. I'm also the Chair of the Department of Preventive Medicine at Northwestern University in Chicago. This presentation from the Cardiology PC Group in Birmingham, Alabama, on the CVD impact of COVID-19 should be very useful to you in your practice. I am so pleased that my former colleague from residency, Dr. Farrell Mendelsohn, was able to organize this series of presentations for your benefit. All the best to you and others in Asia as you continue to manage the COVID pandemic and the growing epidemic of cardiovascular disease. Enjoy the meetings.
And so this is, become a hot topic over the last several months, or 6 months at least, about how to manage our critically ill patients, because there's been a tendency for them to develop thromboembolic events at a higher percentage than the average population that's been sick that we've seen. And so I'll kind of go over an overview of this topic today. No disclosures related to this talk. So I'm going to start with a few cases. These are real cases here at Princeton that I saw in the last several months. The first one's a 59-year-old female. She has a history of hypertension and sarcoidosis, who actually presented to her primary office here at Princeton with complaint of shortness of breath and chest pain for several weeks. So she kind of put it off, but it gradually worsening. She had COVID diagnosed back on December 24th, but did not require hospitalization. She had an EKG done at the office by her primary. You can see here predominantly just a sinus tachycardia. So they did obviously her symptoms were concerning enough for potential pulmonary embolism, and so they did a CTA on her chest, and you can see here as outlined with the blue lines, that's the pulmonary arteries, and then the red arrow there is a large saddle embolus. And so she was ultimately, we were contacted at that point from the primary office, and she was directly admitted to the hospital. And so we took her to the cath lab, and she underwent ECOS, which is basically thrombolytic catheter placements in the pulmonary arteries, as you can see here. And I just put these little red lines here to indicate the path of the pulmonary arteries, and just to show you the right and left catheters that were placed. And these are, and I'll go over this in a little bit further detail at the end of the procedure, but she did very well, recovered off supplemental oxygen quickly, discharged home 2 days later on Eliquis therapy. I saw her back in the office probably maybe 3 weeks ago, looked great, walking around, no oxygen. That was an interesting case that we have seen post-COVID. The second is a 56-year-old with hypertension, fibrocystic breast disease, depression. She came to the emergency room with a complaint of right foot pain and swelling, and her second middle toe was numb and tingling. This had been present for about a week. She was not able to bear weight on her right foot, and she was actually diagnosed with COVID 2 weeks ago. and did not require hospitalization. You could see her exam here. She had decreased pulses as well as very tender to touch on her foot. So we ended up, based off the studies, it was concerned that she had some sort of thrombotic event in her lower extremity, and we ended up taking her to the cath lab, performing an arteriogram, and this is looking at her below the knee and for popliteal vessels. And you can see here this red line indicates that she's got a complete occlusion, acute occlusion of her anterior tibial artery. This line should be going all the way through here, and she has thrombus throughout that and occlusion of the vessel. So we were able to open that up and revascularize that. She was placed on Eliquis as well as Pleatal, and went home, and I saw her back in the office, and she actually was doing much better as well. So those are just kind of two cases to kind of highlight the thromboembolic events we are seeing with this virus. So quickly, the COVID-19 pandemic obviously first reported in December of 19, to our knowledge, caused by the severe acute respiratory syndrome coronavirus. As of a month ago or a few weeks ago, there were 110 million cases with 2.4 million deaths, all ages at risk. But as we know, most of the people, the probability of serious disease goes up above age 60, nursing home patients with chronic medical conditions. Just a few little kind of basic facts that are out there right now. About 14% of the cases require hospitalization, 6 times more common among patients with underlying conditions, and then ICU mits are roughly 2% of cases, mortality is 5%. Again, obviously 12 times more common in patients with underlying conditions. You can see here a majority of these patients will have a multiple comorbidities, including 30% with cardiovascular disease, 30% with diabetes, and 18% with lung disease. The incubation period is up to 14 days with a median about 5 days. As you know, there's a wide spectrum of illness. Around 80% can have mild symptoms, which include no pneumonia or mild, 14% severe, and then 5% critical, which would include shock, multi-organ dysfunction. And so, as this was initially considered to be a pulmonary disease, but we've obviously realized that this leads to a lot of problems, leading to cardiac problems, hepatic, neurologic, renal problems. And then thromboembolic events have really been associated with greatest risk in the critically ill patients. And so this is just a kind of an overview. As we know, typically disease transmission occurs through direct contact with respiratory droplets or aerosols. Patients can have fever, gastrointestinal manifestations, cardiovascular complications, and then shortness of breath due to the inflammatory response. So the association between COVID and thromboembolic events is really related to the prothrombotic state due to the increased in the several different products in the blood, including fibrin degradation products, fibrinogen and D-dimers. And then there's been some studies that shown that these markers indicate worse clinical outcomes when elevated. And so you have obviously your risk factors, your hemostatic abnormalities, and then obviously your inflammatory response leading to endothelial dysfunction with obviously a superimposed infection such as pneumonia, ultimately leading to these bad outcomes in these patients. And so this is kind of a busy slide, but I think this is actually a very important slide because it really shows how complex this virus is. You have on the left side of the screen, you have the virus attaching to the ACE2 receptor on the cell, which leads to viral invasion. And then from there, it really is kind of a free-for-all for this virus because it leads to multiple different pathways, including attacking T cells, macrophages, endothelial cells, ultimately leading to this cytokine storm that everybody kind of discussed several months ago about why these people are getting so sick, which increases these IL-6, IL-7 factors. And this in essence leads to plaque instability, a prothrombotic state, and can cause everything from our acute coronary syndromes, our myocarditis, our pulmonary thromboembolisms, and then ultimately myocardial dysfunction and damage, which could lead to arrhythmias. Cardiovascular complications, this is, we're looking at essentially data within the last year for this, and so what we're going off here is not a decade of evidence. It's just really predominantly case reports and retrospective analysis. But major arterial venous thrombosis, there's been shown to be as high as 35% in ICU patients, with major adverse cardiovascular events as high as 45% in ICU patients. And then going down to symptomatic venous thromboembolism, there's been some studies that show that despite prophylaxis, so these patients taking anticoagulation, there's been as high as 90% still developing that. But again, this is all, a lot of these are retrospective kind of case reports. There's no randomized control trials. And then the last kind of pictorial slide here, just showing you again all these risk factors, the hypoxia, the cytokine storm, all of this kind of mixing together, causing the hemostatic abnormalities. So is COVID-19 associated with an increased risk for venous thromboembolism? Well, yes, but the incident varies, depends on the patient population. There's been meta-analysis on hospitalized patients on prophylaxis, which is shown as high as 14%, and then using ultrasound screening as high as 40%. And then if you look at the same data in non-COVID patients hospitalized previously, you can see here there's a much, 0.3 to 1% symptomatic versus and 3 to 6% overall. So there is obviously an increased incidence for venous thromboembolism in these patients, but it really varies on what study and how you're evaluating these patients. And this is just kind of highlighting what I mentioned again, as we already spoke about the anti-inflammatory cytokines, the sepsis-induced endothelial injury, which occurs normally in septic patients, but is really exacerbated in this condition. And then additional risk factors, obviously these patients are immobile. Typically they're hypoxic, they're prone positioning, as Dr. Sibley mentioned early on in these ventilator patients. And then they're isolated. A lot of times in the ICUs, they'll be they have infrequent position changes because no one, we don't want to come in contact with them as little as possible. So there's a lot of other factors that promote thrombosis. Majority of my information comes from these guidelines. This is the NIH Anti-Thrombotic Therapy Guidelines, and this was updated as of a few weeks ago or less than a month ago. You can get a lot of information out there. Majority of it is, somebody's opinion, and this is opinion as well, expert opinion, but at least it's kind of endorsed by multiple societies. And you can see this is the quality of evidence, and I'll highlight level 3 expert opinion, and then level A or strength A. Majority of this is going to be quality of evidence 3, which is expert opinion, because we just don't have randomized trials at this time. Laboratory testing, there are really no currently data to support measurement of coag markers as an outpatient for these patients, so not really an indication to check D-dimer and all that on an outpatient with COVID. Hospitalized patient, yes, we do that now, but there's not really a lot of evidence to support that from a trial, but that is our kind of current standard of care. So if a patient's already receiving anticoagulation or antiplatelet therapy prior to this, they should continue. At one point there was some concern that they may need to stop certain medications, but that's not the situation. So there's really insufficient data at this time to recommend for or against for or against routine DVT screening in COVID patients without signs, regardless if they have elevated D-dimer or not. For hospitalized patients who have a rapid deterioration, sudden loss of perfusion, obviously pulmonary collapse or something like that, hemodynamic collapse, you should consider the possibility of thromboembolism. Non-hospitalized patients, the recommendations at this time are anticoagulation and antiplatelet therapy should not be initiated for the prevention of venous thromboembolism or arterial thromboembolism unless they have another indication. So this is, again, a hot topic. A lot of people want to know if they should be put on anticoagulation if they have COVID while at home. As of right now, again, this is a level 3, so this is expert opinion. We don't have trials to support this recommendation to give them anticoagulation. Hospitalized patients should definitely receive prophylactic dose anticoagulation, and there really should not be any indication for antiplatelet therapy or anticoagulation to prevent an arterial thrombosis outside the usual standard of care. So what is the recommended venous thromboembolism prophylaxis in patients with COVID-19? So really the recommendation is to utilize low molecular weight heparin, enoxaparin over unfractionated to reduce contact, so we're not having to constantly check PTTs. Optimal anticoagulation dosing is, and which I'll go into in detail after this slide a little bit further, but is actively being investigated. So the American Society of Hematology suggests utilizing prophylactic intensity over intermediate or therapeutic anticoagulation in patients with COVID-19 critical illness who do not have a confirmed DVT or pulmonary embolism. So that is kind of their guidelines at this time. There are other societies that have different guidelines. So this is kind of the hot topic over the last probably 4 or 5 months. Should therapeutic dose anticoagulation be empirically used in COVID patients with the absence of confirmed or suspected VTE? So basically putting everybody on full dose anticoagulation regardless, would this improve? And so this really started back in New York at Mount Sinai it's hard to believe, almost a year ago. I was reviewing some of the literature the other night, and it's hard to believe it's been a year, but this was coming from their information when everything was so bad there, that they looked at these patients in the hospital and tried to see if giving them full dose anticoagulation would increase their survival. But the problem with these studies is, as you can see here, there's a lot of bias associated with these. There's survivor bias and confounding by indication, a lot of different types of bias and these are not randomized at all. But they did find that longer duration of anticoagulation was associated with lower mortality in mechanically ventilated patients, and that there were some other studies at that time showed some benefit. And so this came out in JACC sometime around April or March, and showed that patients requiring mechanical ventilation on therapeutic anticoagulation actually did better than their counterparts that did not receive it. And so there was a big hype at that time to maybe consider putting these patients on a full dose anticoagulation, or all patients in general. And so this came out just within the last 2 months, and again, this is really just interim analysis. This is actually not even peer reviewed yet, and so this is just kind of how crazy our world is at this time, is how things are getting published that are not even peer reviewed. Of course, this is not published, but this is out there because of kind of the times we're in. We don't have a lot of time to wait and have things peer reviewed to potentially save lives. But they basically, there's a multi-platform randomized control trial, and it looked at would therapeutic anticoagulation safely improve outcomes, and this came from 3 trial platforms worldwide. This is over 1,000 patients, and looked at 2 different types of, 2 different populations. One, intensive care, critically ill patients, and other moderately ill patients. And you can see here the primary outcome was 21-day organ support-free days, basically meaning that they weren't requiring some sort of mechanical support, ECMO, high-flow nasal cannula, and then secondary outcomes were listed here. And so what they found is that for the severe state, so patients that required ICU level of care, they actually reported at the end of December that they had to stop this trial or this enrollment because there was futility in full-dose anticoagulation in critically ill patients. Actually, the risk outweighed the benefit in these patients, and so they discouraged the use of full-dose anticoagulation in critically ill patients with COVID-19, which was a little bit the opposite of what everybody was expecting in this situation. However, patients not requiring ICU level of care, moderately ill, as you can see here, is superior, full-dose anticoagulation is superior to usual care prophylaxis. So very kind of strange outcomes in this study, but as you can see here, until peer-reviewed data is available, they recommend to use clinical judgment with consideration of risk of bleeding. And you can see this is the pre-publication interim data here, but without getting into the details here, you can see that the severe state on the right and moderate state on the left, there was a higher risk of mortality by using anticoagulation in the severe state versus the moderate state. And so the question is, why the discrepant results? Well, there's a lot of speculation about timing of treatment. You know, ICU patients, the thought is maybe it's just too late, that these patients are already sick and you're starting the anticoagulation too late in the cascade, may prevent new thrombosis but doesn't really change the course of the illness. Non-ICU patients, you have this potential window of opportunity that you can prevent microvascular thrombosis. And also the possible use of unfractionated heparin in ICU could have influenced the findings in the sense that it's difficult to really keep these patients in therapeutic range. So is there a time to change practice for these patients? Well, not necessarily. I think we're going to have to wait on the guidelines to reflect kind of the full published data. But really what it has done in some places has put a brake on using therapeutic anticoagulation in all ICU patients with COVID-19. But from what I can read is it's just really kind of the Wild West out there. You know, you've got, you know, one center, major center in the country saying that they should all have it, and then another major center saying they shouldn't. So I don't think anybody really knows what the right answer is right now, because still the data we're using, again, is all really kind of early non-peer-reviewed data. There's also some unknowns. Moderately ill patients started on full-dose anticoagulation and then that deteriorate to the ICU. In one of the studies, it was not really clear that keeping them on full-dose anticoagulation was the right approach, because those patients actually did worse. And so there's also a question about using platelet inhibitors in patients as well. So everyone agrees that we should give some form of anticoagulation to all, but no definite answers regarding the best regimen. This is just basically saying, are there any scenarios where we should consider therapeutic anticoagulation? And I think there is if you have a high clinical suspicion, but there's no possibility of performing imaging studies in some of these patients. So, you know, you have a patient that suddenly is intubated and has a sudden collapse. You ought to consider that patient as potentially having a thromboembolic event. And then obviously patients with respiratory failure with high D-dimer or fibrinogen levels when other causes are not identified. Some of these patients, you know, you just have to use best clinical judgment on potentially go ahead and empirically starting them on anticoagulation if imaging is not available. One of the other big questions I always get asked is, should patients receive post-discharge prophylaxis? And really the answer is we don't know. It's currently still being investigated in clinical trials. There's a lot of kind of case series and studies looking at it that do support it. But I think, again, you have to use the individual's risk factors, including, do they have reduced mobility? Do they have a higher bleeding risk? Also, with this home hospital approach, meaning trying to get people out of the hospital and treating them at home, they're still with a reduced mobility. We might want to consider prophylaxis with them. This is really just showing you kind of just to be aware that there are medications out there now being used for COVID-19 virus that can potentially interact with certain anticoagulants, like some of the more of these medicines, Kevzara, and these types of medicines are like rheumatoid arthritis meds, the biologics, as well as the protease inhibitors, all can potentially decrease the effectiveness of these medicines, and just to be aware that there are potential interactions. So one of the questions is, if we can't, how do we diagnose PE if the patient must remain in isolation or is too unstable? And so one of the few things you can do here is obviously if it's high risk that you think they have something, to go ahead and empirically start them on the medication. But a D-dimer does effectively rule out PE and DVT. Now, obviously, majority of these patients are going to have elevated D-dimers, but if by chance they did have a normal D-dimer in a patient that was not necessarily critically ill, you could have reasonable confidence that a PE and DVT is not present. So kind of the last few minutes, I'm going to finish up with a few brief kind of just slides on pulmonary thromboembolism, because this is associated with this. You can see that the mortality, even out to 3 months, is truly devastating on these patients, with a sudden death presenting symptom at 34%. And the ones that we consider for this thrombolytic catheter typically fall in the submassive and massive pulmonary embolism, as you can see here. And so that's a smaller percentage of our patients, the massive and submassive, but the mortality, as you can see, can go anywhere from 21% to 60% at 3 months with this degree of type of pulmonary embolism. And so one of the things we look at is right ventricular dysfunction, RV versus LV size. And so we know that if you have a dilated RV greater than your LV, it's been clearly indicated in multiple studies that these patients do significantly worse, not only as for in-hospital mortality, but even out over 3 months, a significantly higher, worse outcome with RV dysfunction. And so the standard of therapy you can see here, there's typically anticoagulation with low molecular weight is as effective as unfractionated heparin, followed by anticoagulation. But looking at thrombolysis, there is a role for that still. Now, it's been shown in multiple studies in the past that if you give thrombolysis to these patients, they will have decreased mortality, as well as recurrent PE or death, obviously with the downside being a higher risk of bleeding. And so one of the things that we do here to try to get around this, which has been shown as the directed thrombolysis for PE, and you can see here this is the right and left pulmonary artery with thrombus in the pulmonary artery here, with the ECOS catheters being placed in the pulmonary arteries. And this has been studied over the last several years, and it's very clear that this is associated with improved right ventricular function, reduced clot burden, with much less risk of systemic bleeding complications versus systemic thrombolysis. And so I think this is my last slide here. So the last question is, if a patient is empirically started on it for PE, how long should they be anticoagulated? So really, regardless of whether or not you found a thromboembolic complication or not, if you still were concerned that that was the event, they should recommend 3 months of therapeutic regimen. after 3 months, the anticoagulation can stop if they've recovered from COVID-19. Now, obviously, if they truly had a pulmonary thromboembolism, you would want to continue it further than that. And I believe that is it.
Today I'm pleased to bring you a brief summary of the video you've just observed about thromboembolism and COVID-19. Thromboembolism is at the core of many of the complications of COVID-19, particularly the cardiovascular complications that we see and that we're reviewing in other talks that you can see in this series. This is a complicated issue, and unfortunately, our speaker today was not able to present you clear management decisions in the use of these patients, but because ongoing studies have been uncertain about when and how to use which thrombolytic agents and the use of the various complications caused by thromboembolism with COVID-19, this remains an issue that requires your good clinical judgment in making decisions about each patient. Now, the thromboembolism is thought to be caused by a combination of inflammation and immunological issues related to the thrombotic process. The thrombosis that we see as a complication of COVID-19 is both venous and arterial, and so issues like deep vein thrombosis and pulmonary embolus are seen from venous thrombosis, and issues like ischemic stroke and myocardial infarction and peripheral arterial disease can be seen in patients with COVID-19. So, as mentioned, the prevention and therapy, ideally, that we need to apply to our patients is still uncertain. Studies are ongoing, both in Asia, in Europe, in the United States, and I hope that soon we'll have better answers about this issue. In the meantime, we all need to do our best to follow the guidelines that are available for the particular complications, different for stroke, different for myocardial infarction, different for pulmonary embolus, and just encourage you to stay up to date with all of the issues related to thromboembolism as a complication of COVID-19. I hope the talk today has been useful for you as well as this brief summary. Have a good day as you continue to take care of your complicated patients. Thank you.
Greetings, my name is Dr. Charlie Sands, and I serve as chair of MedEd Global's advisory board. As an international medical education service provider, MedEd Global is excited to have provided this outstanding review of the cardiovascular complications of COVID. Our mission is to promote superior education and training for international healthcare personnel. I sincerely hope that this educational video has proven to be of help to you and your colleagues. If you'd like to discuss ways in which you can support or become a part of MedEd Global, our contact information will appear on the screen momentarily. Thank you for the opportunity to share this important information on the cardiovascular complications of COVID.